So the typical symptoms of functional dyspepsia are early satiation. That means you start to eat a meal and you're full too rapidly, and then excessive fullness after meals, and then pain and burning in the stomach region. And the stomach region is between the umbilicus, the lower end of the sternum, and in the middle of the body. So if you have any of these symptoms for a long time and you have had a negative endoscopy, this is what you need to be diagnosed with functional dyspepsia. And this is very prevalent. This is around 15% of the population. And although there's only 4 cardinal symptoms, it's a little bit more complex than that, because very often other symptoms are associated, like bloating in the upper abdomen, like heartburn, like nausea. And because of that complexity, which is inherent with the condition, we subdivide it into 2 subcategories, which may have their own characteristics, pathophysiology, so onset of and mechanism of disease, and treatment. The most important one is postprandial distress syndrome. This is meal-related dyspepsia. It's early satiation and excessive fullness after meals. Very often upper abdominal bloating is in there, and we treat it with drugs that change motor function or volume capacity of the stomach. These may be so-called prokinetic agents. A number of neuromodulators that relax the stomach may actually be used for that as well. And the second condition is epigastric pain syndrome. This is pain and burning, not necessarily related to ingestion of a meal, and this may respond to acid suppressive therapy, so proton pump inhibitors, or to some neuromodulators that focus on the treatment of pain. It's a smaller group in population-based studies, but population-based studies have shown both to exist, PDS and EPS, with a small overlap. And now there are tools, new questionnaires, and new drugs coming for these treatments, for treating these disorders as well. So I think you should watch the space of functional dyspepsia. A lot is going to happen.